بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good evening everybody. Today we have first mock for critical care with Dr. Suzanne. You can start.
Okay, Dr. Pruma and Dr. Yasmin, are you ready to start?
Yes.
Yes. Okay, so we'll do one question for each of you. We'll start with Dr. Pruma.
Okay.
Yaristin is an elderly man who has long history of recurrent epigastric pain presented with sudden generalized abdominal pain. He is confused. ECG and X-ray is in his file. First question for Dr. Pruma. What is the first thing to look for in both X-ray and ECG? Hello?
Yes. I don't know the answer exactly. What?
Dr. Yasmin?
The ID of patient.
Yes,
Yes.
patient's data.
Okay.
Excellent. Dr. Yasmin, how to read ECG?
Reading by first rate and rhythm, B wave and BR interval, Q wave, QRS, and T wave. I will comment every rate by normal rate 60 and to 100. Regular rhythm or irregular rhythm by RR interval, QRS wide or narrow QRS, BR interval prolonged more than 3 square, and the T wave inverted everted T wave.
Dr. Pruma, how to read X-ray?
First, we'll have to see patient's demographic, name, hospital ID, age, sex, and then the date of the X-ray. Is it anterior, posterior, anterior, supine or erect, inspiration or on expiration. Then we'll have to look for the airway, tracheal position. Then reading lung field on both sides, comparing both sides and also pleura. And then we'll have to see the heart size, shape, and position, and also diaphragm, both costodiaphragmatic angle and the level of the diaphragm, and another soft tissue and bones. And also if the X-ray is adequate or not, and if there is any associated other X-ray.
And you have to comment on the trachea, whether it is centralized or not, and the grade vessels for sure.
Yes.
Given the following X-ray, Dr. Yasmin, explain the pathological findings.
Have BA view and explain pathological only air under diaphragm and right side.
Yes, air under the right dome of the diaphragm, because there is air under the left side, but it is not pathological, so we will never mention it. Dr. Pruma, what is your differential diagnosis from the light of this X-ray given to you?
Yes, perforation of hollow viscous, either gastric ulcer or duodenal ulcer. It can be rupture of the diverticulum. There will be necrotizing bowel.
Dr. Yasmin, what will be your management plan for this patient?
And under CRISP protocol, critical patient, I will manage airway maintaining.
What is the name of the protocol, sorry?
CRISP protocol, care.
Don't give abbreviations, please. Give the full name.
Care for critical care ill patient. I will make the airway. I check for airway open and maintain and clean. I give oxygen. I check breathing, air entry, and listen and feel and move. I check chest rising, and I will I insert to both wide bore cannula and take blood sampling and cross matching, and for investigation. I will call for help by the registrar ITU and anesthesia. and I do ECG and I am monitoring the patient. I put the patient in monitor and prepare for laboratory.
And you will start the resuscitation fluid for sure, and you will inform the OR staff that you have a patient with suspected or most probably perforated viscous for OR. Dr. Pluma, in
Yes.
this age group, what other cause of abdominal pain you should consider?
Myocardial infarction.
Sorry,
Myocardial infarction.
which type of myocardial infarction could present with
Inferior-
epigastric pain? Yes, inferior
Inferior
myocardial
MI.
infarction. Yasmin, how to consent such a patient for surgery? He is shocked and confused.
Consent type 4 by 2 consult.
Yes, consent form 4. Dr. Pluma, given the following ECG, explain the findings.
There is irregular heart rate and there is loss of P wave. I think it is atrial fibrillation.
Excellent. Dr. Yasmin, why heart rate value differs between machines and manual counting in atrial fibrillation?
Because the machine not count the weak or the weak beat.
Yes, because in atrial fibrillation, there is even irregularity in the volume of the pulses itself. So the small volume pulse will not be counted by the machine. Pluma, what could be the cause of atrial fibrillation in general, in surgical patient and in this patient? Start by general.
Sorry, start first in this patient.
In this patient, patient has perforated bowels, so there will be sepsis and also electrolyte imbalance, maybe hypokalemia. That's why.
What else?
I don't know.
He's waiting one more. Ischemic heart disease.
Yes.
Don't forget it, please. يلا, continue. Okay, causes of AF in surgical patient. Continue. Answer.
In general, I don't remember actually.
Surgical causes for AF. Why you are waiting? Don't be silent. Answer.
Me?
Or tell boss.
Arrhythmia,
Boss.
valvular heart disease, congenital heart disease, pericarditis due to high blood pressure, cardiomyopathy, like this.
Yes, like this. Like this. What is the problem? كمل يا دكتور سوزان. كمل معانا.
And hyperthyroidism for sure, don't forget it.
Yes, hyperthyroidism.
This is one of the surgical causes of
Stimulation
AF.
and also pain and hypoxia, anemia, stimulation, sympathetic outflow, and cause arrhythmia.
Which type of arrhythmia could be caused by pain?
Yes, most AF in surgical patient caused by pain and electrolyte disturbance.
Could you send the evidence for that, Dr. Yasmin?
Yes, yes.
Thank you.
Dr.
Yasmin.
I'm trusting here, but I won't accept you to answer this. Even give me evidence. Don't go for AF because of pain. Pain will cause sinus tachycardia. Sinus tachycardia.
Yes, that's what I know.
But if Yasmin, even you have evidence, no need to mention it. Okay. Even I'm trusting your evidence, but no need to tell it. Yalla, continue.
Okay, Dr. Yasmin, what are the principles of atrial fibrillation management?
Management, first, I will call the cardiologist and I will maintain rhythm by, I give rhythm control.
No.
And what?
What will you do first? You mentioned all these causes for the AF and you will not manage the cause?
Yes, I will treat the cause, electrolyte disturbance and I will manage
You have
the
sepsis, you have electrolyte
Yeah.
disturbance, so manage the cause first, then you will go for rate control or rhythm control.
okay.
Continue.
I will manage then I will manage I give the patient anticoagulant drug like fractionated heparin and
How much the dose? Give with
dose
full dose.
1 gram per kilogram.
Are you
Therapy.
sure? This is unfractionated heparin dose?
Yes.
No, it is
50. 50.
1880 1880 1880 keep this mnemonics.
1880. Okay.
yes, 18 international unit per kg bolus, then 18 international unit per kg per hour, till
Okay.
your APT is 40 to 60 seconds. It is the dose for unfractionated.
Okay.
Then what will you give?
I give rhythm control Concor
What do you mean by Concor?
beta block.
So tell me the blocker because there are many.
Okay.
What else?
And I don't remember.
You mentioned the rate control. What about the
Yes,
rhythm control?
Yes, rhythm control imidrone.
How much is the dose?
I will give maintenance the bolus dose 300 and then the bull infusion in 42 hour 800.
900 milligram over 24 hours.
Yes,
Total is 120.
yes.
Okay, I finished this station with them. Dr. Salah, do you have any question or any comment for them rather than the hesitation of Dr. Yasmin? Yasmin, now I think you became familiar with our way of discussion. You don't have to be hesitated at all. This hesitation will give the examiner a very bad impression about you. You was very good in the beginning. I don't know why you got panicked.
المشكله عندها الكاركتر بتاعها اساسا هي من الاول كده ياسمين انا عارف المشكله دي عندها من الاول لكن with more practice ياسمين it will be improved. I know your knowledge are amazing from part A. I know that. Just adjust this by more and more practice even outside of our discussion. This is very important. ماشي يا سوزان.
Okay.
I wanted to share something. Why not sharing? You can't start screen while the other is sharing.
Okay, stop sharing.
بتعمل ايه في الجهاز؟ الرسائل على الخاص ديت انا بزعل من نفسي اني ما بعرفش ارد عليها بس اعمل ايه؟ الرسائل على الخاص بحاول والله ارد بس صعب. طيب this picture from a real exam. This picture from real exam as you can see it now. واضحة؟ This picture of exam perforated viscous. Okay. And this is the ECG. Butt cut. ECG here is AF. How to know AF? Absent B wave and irregular. There is irregularity. Okay. This is how to read X-ray, ABCDE after demographic and radiological details. So how to read? If the question coming for you, and the question coming by two ways. This station he will ask you how to read X-ray. If we'll ask you how to read X-ray or giving you X-ray and read this, asking by this way, you will start by we have first demographic, then radiological details, then I will go for interpretation ABCDE, airway, about accreditation or not, plus pneumo hemothorax, breathing. You will look for post lung field disk consolidation or lobar collapse. Circulation, you will go for the pericardium, heart size, then diaphragm, the costophrenic angle, and position and the shape of diaphragm. By this way, if the question asking you, what is the pathological finding in this X-ray? You will tell air under diaphragm. You know the question coming by two ways. How to read the X-ray or could you read this X-ray and show you by this way? So you should tell everything, except if we'll ask you what is the finding in this X-ray? What is the pathological finding? What is the abnormality? So you will answer directly. Okay? This is also how to read X-ray, how to do ECG, how to read ECG. The only question came here. I discussed it in pathology. Already about in this station, a patient has perforated peptic ulcer, asked non-steroidal anti-inflammatory, which enzyme inhibits synthesis of prostaglandin, or what is the mechanism? He will tell you inhibition of prostaglandin. He will tell you which enzyme, COX-1 or 2, COX-1. COX-1. COX-2, this generates prostaglandin, which mediates inflammation, while gastric mucosa by COX-1. This is the only question asked in this station. تمام؟ يلا نيكست يا سوزان.
Dr. Aya and Dr. Haifa, are you ready?
Yes.
Okay, so your stain is a 45-year-old diagnosed and managed for acute pancreatitis. She's a lady, managed for acute pancreatitis 2 weeks ago, now presents with vomiting, shortness of breath, and epigastric pain, which is not improved with PPIs, examination revealed tachycardia and tachypnea. First question for Dr. Aya, which enzymes to be checked apart from amylase and lipase?
LDH hormone.
Are amylase and lipase valuable in diagnosis of pancreatitis, and why?
No, because they are increasing in other conditions.
Yes, they are sensitive, but not specific for pancreatitis. Dr. Haifa, what are the causes of post-cholecystectomy pancreatitis?
This could be because of iatrogenic injury following cholecystectomy, or infection, or missed or retained stone.
Or it could be also due to stricture if it is long-term.
Okay.
Patient comes with jaundice and ascending cholangitis 6 months after surgery. What could be the cause? Dr. Aya.
Could be missed stone, could be stricture, or injury to common bile duct.
What do you mean by injury to the common bile duct that will persist for 6 months?
Sorry, no, 6 months, no. May slip ligation.
Stricture or no, slip ligature will cause piloma. I mentioned this 100 times, which is a collection in the calloid triangle or nearby to the liver, and that will be acute presentation. It will never be after 6 months. Dr. Haifa, 5 weeks after the initial attack, patient presented with epigastric fullness, vomiting, and dyspepsia. What could be the diagnosis?
Pancreatic pseudocyst.
Dr. Aya, define pseudocyst and what are its contents?
It's amylase-rich fluid in capsule of fibrous or granulation tissue. Its content amylase.
Dr. Haifa, it is not amylase, it's amylase-rich fluid. Dr. Haifa, what is the difference between cancer and pseudocyst? Cancer, cyst, and pseudocyst.
This could be differentiated using ultrasound scan or CT scan or cyst fluid analysis. About the cyst fluid, we could check for the viscosity and the CA19-9 and the amylase. The amylase will be increased in pseudocyst, while the viscosity and the CA19-9 will be increased in cancer.
Excellent. Dr. Aya, in case of pancreatic necrosis, what is the investigation of choice?
Abdominal CT with IV contrast, pancreatic protocol.
Excellent. What are the findings to look for in CT, Dr. Haifa?
Edema, abscess, collection, fat strandings, necrosis, and pseudocyst.
Excellent. What are the biochemical findings you will search for in a patient with pancreatitis, Dr. Aya?
Hypocalcemia, less than 2 millimole per liter. Hypoalbuminemia, less than 32 grams per liter. Urea and creatinine, urea more than 16. And I think that's it.
Why is the calcium level low in pancreatitis, Dr. Haifa?
In the acute stage of pancreatitis, there may be saponification, which is the effect of enzymatic lipase on the triglycerides. This will result in the release of free fatty acids, which chelate the calcium, leading to formation of calcium salts, resulting in transient hypoparathyroidism and hypomagnesemia. And in the later stage, as a complication of pancreatitis, there will be sepsis and increased circulating catecholamines. This will lead to shift of the calcium into the intracellular space and resulting in relative hypocalcemia. There is also another explanation that 45% of calcium is bound to the albumin, and as patients with acute pancreatitis have hypoalbuminemia, this will result also in hypocalcemia.
Excellent. Why is there hyperglycemia in a patient with pancreatitis?
Sorry, Suzanne. Don't forget also if patient became complicated by acute renal failure can cause also as organ failure can cause also hypoglycemia, and the destruction of parathormone hormone because of enzymatic proteolytic enzymes can be another cause.
Okay.
Because you did perfect answer. طيب خلاص لازم اعلق عليكي. لازم اعلق عليكي. Write your answer, please. This is very nice answer, especially if you will start by saponification of fat, examiner will be satisfied. And he's waiting this word first. Okay.
Okay. Okay.
Okay, what is the cause of hyperglycemia, Dr. Aya?
Two causes. First one is stress. Second is destruction of beta cell of Langerhans island of the pancreas by enzyme pancreatic enzyme.
How stress will cause hyperglycemia?
Stress response by release of a stress hormone like glucocorticoids, catecholamines, glucagon,
which have anti-insulinic effect.
Okay.
Dr. Haifa, how could you classify obstructive jaundice according to cause?
This could be intraluminal, intramural, and extramural. Intraluminal, such as stones and parasitic infections. Intramural could be drug-induced or strictures, or sclerosing cholangitis, could be malignant, such as cholangiocarcinoma. Extramural could be compression from a pancreatic or gastric tumor.
Yes, and could be due to enlargement of the portohepatic lymph nodes. What could be the cause for silent obstructive jaundice?
Cancer head of the pancreas.
Excellent. How would you manage a patient with acute pancreatitis?
I will manage patient of acute pancreatitis according to care of critically ill surgical patients. I will admit the patient to ITU and will start analgesia and aggressive fluid hydration.
What analgesia will you do?
I will give analgesia according to the WHO letter with avoidance of morphine and non-steroidal anti-inflammatory drugs.
Why?
I will avoid morphine because theoretically it could cause constriction of sphincter of Oddi. And I will avoid because there is risk of peptic ulceration and erosive bleeding.
Continue.
And then I will start invasive monitoring of the patient for the vital signs and the central venous pressure and urine output. And I should monitor the patient biochemically and hematologically by the liver function test and renal function test and glucose and albumin and clotting factors. I maybe need nasogastric drainage only initially. I could administer antibiotics if there are features of sepsis or ascending cholangitis or necrotizing pancreatitis. I should request CT scan if there is organ failure or any clinical deterioration. Endoscopic retrograde cholangiopancreatography is required within 72 hours if there is gallstone, pancreatitis, or features of ascending cholangitis. I should do supportive management if the patient has organ failure, such as hemofiltration or ventilatory support or emmetropes. I should also administer octreotides to decrease pancreatic enzymes and proton pump inhibitors to avoid gastric or stress ulcers.
What about nutritional management or nutritional support for this patient?
Yes, I will consult a dietitian and consider the nutritional status of the patient, and the patient may require enteral feeding or parenteral feeding according to the severity.
Does the steroid have a role in acute pancreatitis management?
Yes, steroids inhibit the release of inflammatory cytokines in acute pancreatitis, and it could be beneficial in patients with severe acute pancreatitis as it decreases the hospital stay and the need for surgical intervention and decreases the mortality rate.
Excellent. Dr. Aya, what scoring for pancreatitis do you know?
Gleason score, Ranson score, and another third one.
You told Gleason score. Is Gleason for pancreatitis?
Again,
Gleason score for pancreatitis is a scoring for prostatic cancer, not for pancreatitis.
I'm
So
sorry,
what
sorry.
else?
Glasgow score.
Glasgow, Branson, what else?
And
Balthazar CT scoring system and
Balthazar CT
Apache 2. Could you talk about each of them in details?
Glasgow score is about partial pressure of oxygen to be less than 8 kPa, and after that age more than 55, neutrophil more than 15,000, calcium less than 2 millimole per liter after 48 hours of admission, urea more than 16, LDH enzyme more than 600, and blood sugar more than 10, and albumin less than 32 gram per liter. At least we need 3 of them to say it's a severe attack of acute pancreatitis and require ITU admission. Ranson score is divided into point for at the admission and point after 48 hours of admission. At admission, for the age of the patient, more than 55, leukocytic count more than 16,000, and LDH more than 350, blood sugar more than 11 millimole per liter, and EST more than 250. And for after admission by 48 hours, calcium less than 2 millimole per liter, blood urea nitrogen more than 1.98, even after good rehydration, fluid resuscitation, base deficit more than 4, and fluid sequestration more than 6 liter, and partial pressure of oxygen less than 8 kPa, and hematocrit drop more than 10%. Balthazar CT scoring, it's depend on the CT order 3 to 5 days after onset of pancreatitis. 0 or A is given for normal pancreas, B given 1 point for edema in the pancreas, C given if there is inflammatory change in the pancreas or peripancreatic fat, it's given 2 points, D for ill-defined peripancreatic collection, and E given for 2 or more ill-defined pancreatic collection.
What is the benefit of Ranson criteria? We do it for what?
To decide is it a severe, mild, or moderate attack?
No, it's for mortality rate, not for severity. Severity by Glasgow criteria. Mortality rate by Ranson's criteria. In Ranson's criteria, what are the criteria you should order after 48 hours? In Glasgow.
In Glasgow, calcium,
What
albumin, calcium and albumin,
What
and LDH enzyme.
Excellent. Well done. Dr. Haifa, what are the early and delayed complications of acute pancreatitis?
The early complications could be acute respiratory distress syndrome or pleural effusion or metabolic disturbances such as hypoxemia, hypoalbuminemia, hypocalcemia, hypomagnesemia, and hyperglycemia. And these could be pancreatic necrosis also. About the late complications could be pseudocyst and pseudoaneurysms.
pseudoaneurysm
Yes.
in which vessel?
Splenic.
Splenic
I'm not
vein
sure is it.
thrombosis, not pseudoaneurysm. Splenic
Okay.
vein thrombosis.
Okay.
Dr. Aya, how to treat splenic vein thrombosis in a patient with hemorrhagic pseudocyst?
Interventional radiology by coiling.
What are the complications of coiling?
Injury to adjacent structures or hemorrhage, or it could the failure and infection.
Excellent, well done. It is not an easy station, but it's clear that you studied it well and you answered perfectly. Dr. Salah, do you have any more questions for them? Or
Did
you
you-
have any comment?
Did you ask them about pain management in this case and the
Yes. Dr. Haifa explained in detail.
again answer Dr. Haifa about pain management for this patient?
I will manage the pain according to the WHO letter with avoidance of morphine and non-steroid and anti-inflammatory drugs.
Why you will avoid morphine?
Because theoretically it may cause constriction of sphincter of Oddi.
Theoretically.
Yes.
So what is the best pain management for patient with acute pancreatitis?
Epidural and patient-controlled analgesia.
What?
Epidural anesthesia and patient-controlled PCA.
PCA and epidural. Excellent.
Epidural.
Yes. Okay. What about antibiotic for acute pancreatitis? Do you order acute? Will you order a antibiotic for patient with acute pancreatitis?
In case of severe infected necrotic pancreatitis, or in case of sepsis, or before any intervention as RCP.
Okay. So in treatment of infected necrosis, treatment of systemic infection in patient 24 sepsis, and prophylaxis in severe necrotic pancreatitis, plus prophylaxis if you do any invasive procedure like ERCP. Okay. This patient is tachypnic. What may be the possible causes for tachypnea?
May compression by pseudocysts, may other respiratory distress syndrome as a complication of acute pancreatitis. The pain
Or
itself.
for the abdominal pain.
What?
The abdominal pain.
Pain. Sympathetic overdriving. Sympathetic overdrive is splinting of diaphragm by huge pseudocyst and the arteries. I think why amylase will give me two situations for amylase to be normal in this patient.
Very early or very late.
Why?
Because it's released in blood within first few hours of the attack, and after that return to normal level. And in case of acute on top of chronic or hyperlipidemia,
Okay.
need serial dilution.
Excellent. Regarding of scoring systems, every time he's asking you the scoring system and will ask you pick up one only and discuss about it. But this station when came in UK, he was discussing about all scoring. For sure, station is very long. Station is very long. So we don't know. Yani we'll do scoring or not all scoring. So better to keep all of the scoring. We don't know what is the situation. This station keep in the Middle East for a long time. But they like this station in UK since a long time. But now we have around 2 or 3 years after Corona, they didn't bring acute pancreatitis. But so take care. If they want to update or making exam difficult, they will start to bring the old stations. Yalla, Suzanne, they are doing great.
Okay, thank you, Dr. Haifa and Dr. Aya. Dr. Rami and Dr. Adnan, please unmute your mics.
Before going to discussion with them, I wanted to confirm about critical care topics I didn't mention at the beginning. The most difficult part in your exam, it will be critical care in knowledge. Why? Critical care mainly they are looking for you understand or you can't understand. You have four marks for professionalism. It will be here. يعني anatomy it has no marks for professionalism. Pathology no marks for professionalism. يعني anatomy 20 marks total will be according to the questions. Pathology is the same, but here you have 4 marks for professionalism. Some of you will come, Dr. Salah, why I get low score in knowledge? Already I answered the question, except only 1 or 2 questions in critical care. I can't answer them. You didn't miss the 2 questions. You missed also the professionalism marks. Total questions 16, and you have 4 for professionalism. Critical care, every time he's asking you questions and not satisfied. And many asked me, why are they are not satisfied? He's waiting for you clear explanation. Like discussion now with Dr. Aya and Dr. Haifa. I like this discussion, by the way. I think by this way you can score 20 from 20 easily. You will get professionalism marks by this way. Yalla.
Okay, Dr. Rani and Dr. Hassan. Dr. Adnan is not unmuting his mic.
Okay, hello.
Hello.
Dr. Suzanne. Hello, Dr. Salah.
Work.
Fine, alhamdulillah. Okay, so we'll start by Dr. Rami, then Dr. Hassan. Rustam is a pregnant lady, 34 weeks, undergoing open cholecystectomy for a gangrenous gallbladder under epidural anesthesia. Intraoperative, she developed tachycardia and her blood pressure dropped. First question for Dr. Rami, could you define preload, please?
The preload is the amount of venous return which distends the right ventricle or left ventricle to its greatest dimension.
Dr. Hussam, what are the factors governing the preload?
Factors covering preload.
Yes.
It's about this factor is about the stroke volume.
What else?
Yeah, it's about the contractility or heart rate and stroke volume,
What else?
and the systemic vascular resistance.
Excellent. And venous drainage for sure.
Okay.
Why blood pressure dropped in this patient? What is the cause of her hypertension? Dr. Rami.
There is a multiple causes for drop in the blood pressure. First of all is the reversed Trendelenburg position.
Did I mention that this patient is in a reversed Trendelenburg position? I didn't mention, so do not put answers from or scenarios from your mind, please. Answer according to the scenario given to you. Please, continue.
Okay, maybe due to the pregnancy and the gravid uterus compressing the inferior vena cava, decreasing the venous return.
What else?
Also maybe due to septicemia causing vasodilatation and pooling of the blood in the periphery. Also may be cause of the epidural anesthesia or spinal anesthesia, which causes vasodilatation and the pooling of the blood in the peripheries.
It is epidural because the spinal could not be used for cholecystectomy. The level of spinal is lower. Do you think this surgery is necessary, Dr. Hussam? And give the factors for and against, please.
Okay, here surgery it may be necessary because to prevent premature labor or intrauterine fetal death due to sepsis. Factors for against this one, okay, because in after surgery or in surgery it may cause intrauterine fetal death and also may cause premature labor and also may cause DVT due to long standing.
Why it could cause intrauterine fetal death?
What?
The patient could die because of sepsis if surgery not done. But what killed the baby if you do the surgery?
What killed the baby because
you told
sepsis.
The one of the against was one of the factors against your surgery is intrauterine fetal death.
Okay, because there may be hypotension due to bleeding during surgery, and may cause a baby cause ischemia. Okay, may cause intrauterine fetal death. Also, maybe due to sedation for anesthesia.
Sedation will not kill the baby. Maybe the anesthetic medication, but not the sedation for sure, because the baby will be floppy baby, but he will not die.
Okay.
But he could die because of sepsis if we delay the surgery or if we do not do it. Okay, what would you do to improve the patient's condition? Your patient is now hypotensive. How you could correct the situation of your patient?
For me,
Yes, the questions are one by one between you.
we can give intravenous fluids. Also, we can correct any position if it's not in the correct position to improve the venous return.
What do you mean by correct the position?
Sorry, we didn't mention Trendelenburg. So we can give intravenous fluids, can give inotropic support for.
Actually, you have to correct the position, but the position of the baby over the inferior vena cava, because it is pressing over it. So we need to put the patient on left lateral position or right lateral position, whatever it is, to avoid this pressure, so that will improve her condition. What else?
Give inotropic intravenous fluids and inotropic support.
And vasopressors for sure, if needed. Okay, how the venous return differs in standing versus supine position?
In standing, there would be the effect of gravity, as when the patient stands, the blood pools in the peripherals and lower limbs, which make increase the resistance and also prevent the blood from backing to the IVC. Then will cause the lower venous return and will cause the hypertension.
And what about in supine position?
In supine position, so the effect of gravity will be removed, and also the blood will be in the same level. So the venous return will be increased.
The venous return will be lower or lesser than in supine position because of gravity. Am I right?
Okay. Right.
Thank you. How to prevent DVT in this patient? You told one of the complications on one of the factors against your surgery is DVT, risk of DVT. How to prevent it?
We can give adequate hydration and intravenous fluids during and after the surgery. Also, we can use intermittent pneumatic compression or thromboembolic deterrent stockings. We can also limit the time or shorten the time of the surgery as possible to diminish the risk of DVT.
Could you start prophylactic anticoagulation for this patient?
Sorry, what do you mean by prophylactic?
Prophylactic anticoagulation to prevent DVT. Could you start it for her?
Pre-operative or post-operative?
Pre-op for sure.
Yes.
Yes, it's one of the modalities to prevent DVT. What is the mechanism of action of DVT stocking, Dr. Hassan?
DVT stocking is cause compression to the lower limb, so it will encourage the moving of the blood in the lower limb and prevent to be stasis in the side.
Yes, prevent stasis. Excellent. Okay, well done. We finish our station, Dr.
But
Salah,
I think I have some, but I just read before, because about DVT, the patient, before we give it prophylactic DVT, we put it in a scoring system. It's in a hospital. It's like a paper. We give us a score if it's need to take prophylactic or not, or just prophylactic anticoagulant, or just modification, life modification.
Yes, for sure.
السكورنج ده اسمه ايه وتعمله ازاي؟
هو بصراحه مش فاكر الديتيلز بتاعته كامله، لان هو طويل، كنا بنقعد نطول في الوقت بتاعته، بس هو
So now you have a pregnant lady who is going for a surgery, open cholecystectomy, which will take more than 45 minutes for sure. What do you think? Is she a candidate for this prophylaxis or not? Without seeing the patient, without knowing her BMI even.
It will be candidates for prophylactic.
That's what I think. Excellent.
يا سوزان اللجنه دي. طيب you heard about Will's scoring or no? Hello?
I think they muted their mics already.
لا لا
No,
افتحوا.
I am here. I didn't hear about it.
لا اتهم. طيب اسمعوا بقى حاجه عايز اقولها لكم، انا ما قلتهاش قبل كده بس انا هقولها بقى وهتحفظوها. معلش ليه؟ انا مش مطمن للانجليز. بص يا سوزان، انت في انجلترا دلوقتي ولا رايحه زياره؟
No, I'm there now.
وخايفه تقولي ليه؟ خايفه يحسدوكي زي ما خايفه ان انا احسدك ما تقولي. فانت صعبان عليا. طيب طيب شنو ده؟ He talked to me before and he told me, Salah, I wanted to ask you. We have in part A or part B, Will's criteria or Will's score? I told him no. How I know Will's score? Because I am responsible for DVT, for VTE, VTE prophylaxis in hospitals nowadays in Saudi Arabia. They have a specific one for that. أنا المسؤول عن قسم العظام. So I take courses for VTE prophylaxis. Will's criteria or Will's score? It's a big score, by the way. And this, they are following it in UK. Any patient there, they will choose a score before going for surgery. هل انت شفت ده يا سوزان ولا لسه ما شفتوش؟
Not yet, but we were using it in Saudi Arabia.
لا ويلز سكورنج لا مع مش الويلز سكور مش الويلز سكور. We have a big chart about VTE prophylaxis. They are following the Will's score. So please, if you want to about especially for the question of prophylaxis, you can tell according to the Will's score. According to the Will's score, a patient is likely or unlikely, high risk, moderate risk, or low risk. You can tell according to Will's score. If we'll ask you what is Will's score, I shared it for you. يعني you can tell him long time I didn't read it. خلاص enough. يعني if you will start that you know Will's score, I think you will not go deep. But if you want to keep it, because we don't know what will happen nowadays. Okay. Right. This is number one. Mechanism of stocking I shared already. The mechanism of stocking, beside what you told, if you will do compression, so this will direct the blood flow upward, and this is not to the superficial veins or to the foot. It will go in the deep system. So this blood will go there, decrease the diameter of vein also because of compression. This will increase also the velocity of blood flow. So you have two things for this mechanism. Number one, the compression itself will direct blood upwards in the deep system, and a compression also will decrease the diameter of vein, so increase the velocity, so increase the pump, increase the pump, or increase venous return. طيب regarding of one question, and this station coming by this way, discussion 100% it will be by this way. Don't worry. Except the question for bradycardia. Could any one of you can explain for me why this patient has bradycardia? All answers not accepted till now. All answers not accepted till now. يلا.
Bradycardia occur about it not will be neurogenic shock because the sedation, it will general anesthesia, it's not regional anesthesia or epidural, so it will be excluded.
Why? I know how epidural. What is the mechanism for epidural to cause bradycardia?
So it will be high level, so it will affect the cardiac accelerator sympathetic effect, so it's cause bradycardia. Also, it means the type.
If it will affect the sympathetic, this will cause tachycardia, not bradycardia.
I need the morphine.
Why morphine? I'm talking about epidural. Epidural. How it cause bradycardia? All your answers not accepted. بص يا سوزان كده. This from وقفي لي انت مش هيقراها. هو انا ليه مش عارف اشير؟
I don't know what the host.
طيب. Written before that anesthesia will cause vasodilation and inhibition of sympathetic activity or inhibition of the sympathetic tone. So bradycardia hypotension will be the result because of vasodilation. This is not accepted. This from care of critical ill surgical patient, the last edition. What is written here? Sudden withdrawal of epidural analgesia or epidural anesthesia can cause acute afterload increase in patient while increasing preload as the sympathetic blocks wear off. Forget this. I think written here, bradycardia as a result of vagal reflex is mediated by potent abdominal wall traction and potentiated by epidural analgesia. So you will tell because of sympathetic tone and increased vagal reflex because of which is mediated mainly by abdominal wall traction and aggravated or potentiated by epidural analgesia. I hope this answer will be accepted. حد ما يطلع من الامتحان يبقى يقول لي accepted ولا لا. This from care of critical surgical patient book. تمام. يلا نكمل.
Okay, Dr. Farheen, please raise your hand because I can't find you. Okay, Dr. Omar.
I shared the notes group. I shared it in notes group.
Hi, Susan.
Hi, how are you? Are you ready?
Not too bad, thanks.
Very nice. Okay, so your first study, the critically burned ill patient is anxiety or requires nutrition. In this station, you will be asked the physiology of nutrition and its clinical application.
Okay.
بديل كله ورا بعضه.
Given these two X-rays, compare the finding in both of them.
The X-ray on the right has a safe nasogastric tube with a tip clearly below the diaphragm on the left side. The one on the left, we can barely see the nasogastric tube. Probably is misplaced or it's not in the gastric.
How to confirm that the NGT is in place?
By imaging X-ray, it's always the primary modality. We can also use check the pH with a pH indicator of the aspirate.
If you check the pH of the aspirate and it is 5.5, what to do?
It just means it's in the wrong place. It's alkalotic, or probably needs to reposition the NG tube and do X-ray.
Excellent. The second stem is a 55-year-old man with long-standing Crohn's disease admitted with abdominal pain and vomiting for 5 days. His weight was 52 kg before his recent illness. Abdomen was mildly tender, distended and tympanic. On percussion, ileocecal resection with primary anastomosis done, but he was taken to OR 4 days later with anastomotic leak with for laparotomy and ileostomy done for him. Okay. Given this X-ray, what are the findings or what could be the diagnosis for this patient?
I must say it's a difficult X-ray to read, but I think the bowels are dilated.
Which part of the bowel would you recognize?
Probably the small bowel.
Yes, so what could be the diagnosis here?
Probably a stricture, or given the history of Crohn's,
Yes,
Or
a small bowel obstruction, mostly due to stricture due to Crohn's. Excellent. And here, these dilated loops are jejunal loops, small bowel.
okay.
What could be the cause of intestinal obstruction in this patient? I think you answered already. The most common cause or the most predicted cause is Crohn's stricture, and it could be very early adhesions, which is not common in this time. What are the feeding options to use for this patient?
I mean, given the obstruction, I think the patient needs needs parenteral feeding, either partial or total.
And now the surgery done already, and we did the laparotomy and ileostomy. What could be the options of feeding for him?
Okay. Oh yes. Yeah. So enteral feeding could also be option. Yeah, you're right.
Yes, we have to start enteral feeding as soon as possible for him. What are the components of TPN?
So we should have the major energy supply of carbohydrates, proteins, and fats, and also the trace elements and vitamins. In terms of ratio, it's usually 50% carbohydrate, and probably 30% fat, and the rest should go to protein and elements.
What are the disadvantages of using only glucose as energy source in post-operative patient?
Well, essentially, there will be under provision of calories for the patient. Also, other causes like respiratory problems could be encountered because of carbon dioxide production, which could lead into respiratory failure. Also, hyperglycemic control will be a problem. I think these are the three reasons I can raise.
Actually, this patient is hyperglycemic because of the stress response to surgery. So what will be the problem with this hyperglycemia?
It should, there should be glucose intolerance, so it should be worse. And fatty, you probably will have fatty liver as well.
Yes,
Yeah.
and deranged liver function. And the other cause, as you mentioned, the extra carbon dioxide released by oxidation of glucose will cause the respiratory failure and increase the ventilatory requirements. Other than glucose, what are the constituents of TPN providing significant energy source?
I think mentioned earlier, protein and fat.
Fats mainly. What are the indications of TPN?
General indications like critical ill patient or patient of burns, and also patient with pancreatitis or ARDS. Other gut problems like short gut bowels is indication for TPN, and a severe malabsorption should also be indication for TPN.
And what are the indications of enteral feeding?
What are the indications for enteral feeding? Generally, I'll probably consider this in terms of the types of the enteral feeding. So we have NG tube. So if you have a patient with low conscious level, you want to prevent the risk of aspiration pneumonia, then you give them an NG tube. Other issues that you can consider NG, if there's pancreatitis and you want to skip worsening of pancreatitis, then you can do an nasogenostomy or to skip pancreatic juice and enzyme production. Obviously, once the acute septic conditions have resolved, then you want to start enteral feeding as soon as possible.
Excellent. Why enteral feeding is preferred over TPN?
Well, again, enteral feeding, it's good for mucosa integrity, was TPN usually is associated with mucosa atrophy. And also, I think the risk of infection with enteral feeding is probably less compared to TPN. Also, issues with venous thrombosis or thrombophlebitis can be avoided with enteral feeding. And also, you could possibly have less respiratory feeding syndrome with enteral feeding as compared to TPN. So Yeah, these are.
Excellent. What is the cause of mucosal atrophy in patients with TPN?
Essentially, in the absence of intestinal or luminal signals, the integrity of the intestine will be disrupted, and that's what you get with TPN. So it's just the absence of feed getting into the intestine would prevent luminal signals from restoring the integrity of the mucus.
Yes, due to reduction of hormones needed to maintain the mucosal integrity. What else?
I'm sorry, I don't know anything else.
Lack of glutamine in the mucosa due to loss of enteral feeding will cause also mucosal atrophy. What is the results of mucosal atrophy? Why we are afraid of it?
Perforation, probably.
No. Bacterial translocation.
Sorry?
And also bacterial translocation.
Bacterial
and loss of cellular adherence.
Okay.
It will not reach to the extent of perforation, inshallah. What are the complications of TPN?
I think we can put them into line complications and then feed complications. So line complications, injury to infection and sepsis, and then thrombophlebitis or venous thrombosis, and then feed problems. You have electrolyte imbalances. You could have underfeeding and overfeeding. Also, you could have issues with I don't want to say malabsorption. Refeeding syndrome is a major problem with TPN. I think it's probably the primary complication of TPN as far as the feeding is concerned.
Okay, so you divide it into line related and substance related or related to the feeding itself. So the line insertion related are immediate and late immediate, like trauma to surrounding structures like carotid artery or the pleura causing pneumothorax, emphysema, air embolism, wear embolism, and there are delayed like infection, as you mentioned, infective endocarditis, and you have the metabolic related to the feeding substance itself, like hyperglycemia, impaired liver function, hyperchloremic acidosis, and for sure, the refeeding syndrome.
Okay.
What is refeeding syndrome and why it's fatal?
Refeeding syndrome is a metabolic complication following feeding after prolonged starvation of a patient. Why it's fatal? It's fatal because it causes severe and significant electrolyte imbalances, hypokalemia, hypomagnesia, hypocalcemia, and hyponatremia, which are very significant elements for physiological functions of the body.
And also will cause vitamin deficiencies like vitamin B1, the same. What are the complications of enteral feeding?
You could have aspiration pneumonia. You could have sinusitis. You could have malposition of the tube, or you could also have refeeding syndrome, and then
metabolic problems like hyperglycemia, hyperkalemia.
Okay,
And
hypokalemia.
other electrolytes imbalance.
All right. This is the last.
What should be monitored regularly during TPN?
During TPN, you want to monitor the electrolyte levels, or what we call the refeeding electrolytes. So magnesium level, potassium levels, sodium levels, and calcium level. Also, you want to monitor the albumin level. And then the anthropometric figures of the patient. So weight, it's very important to measure them regularly. And also you want to measure certain trace elements like zinc, iron, the ferritin, and then routine bloods, including liver functions and renal function.
Why nasovaginal feeding is better than nasogastric feeding?
I think nasogenestoidem skips the gastric component of feeding, which means that there is a rest for the gut. Also, nasogenostem tube are normally, I think, slightly thinner as compared to nasogastric feeding tubes.
Because it bypasses the stomach, as you mentioned, it gives rest to the stomach, it avoids gastric phase of stimulation and doesn't stimulate the pancreas. It is the best for pancreatitis patient. What is TPN ratio of carbohydrate, protein, and fat? I think you answered this question before. Okay, your third stem is the middle-aged man brought to the emergency department with a fractured mandible. What are the indications of mandibular fracture fixation?
Sorry, I don't know this one. I'm going to make things up, so forgive me in advance. I think aesthetic conditions, obviously, it's one of them. Or if it's well displaced, that it disconfigures the patient's facial expressions, then probably you want to fix it. Obviously, mandible is required for mastication and feeding. So if there's severe pain, I think it might be an indication to fix it.
And also cosmetic.
Yeah, that's what I meant by the aesthetic factors.
Excellent. Very long station. It is not an easy station, but you organize the info in your mind in a very nice way, and you are recalling them smoothly. Dr. Salah, do you want to add anything for Dr. Mark?
كل مرة بتقف في اللجنة دي قلت له مش عايز أكملها، والنهارده ما ادتنيش فرصة أقول أي كلمة، أنت بتهزري.
Dr. Salah, you know I don't speak Arabic.
No, you did great. You did great. Every time I have some questions in this station to be added, but
Okay.
Dr. Suzanne, she added everything. This station came in by 3 stems. The last stem 3, came in Oman before by this way, and started by indication of the start about feeding, like discussed with Suzanne exactly, and another stem about burn. And we'll show you 2 X-rays like started with Suzanne exactly. Okay, I think I have nothing to be added. Refeeding syndrome definition already I put. Nutrition station that came in Cairo from the checklist regarding Crohn's disease is the same. They didn't add anything for me. Complications of TBN already enteral and the parenteral feeding I shared also for you in the I shared for you already. Okay.
Okay.
But how you don't know mucosal integrity if will be affected, or mucosal atrophy will cause bacterial translocation? How you don't know? This is the most easy question for them. How you don't know this question?
No, excuse me, I just don't know it.
Okay. Yalla, so the next station.
Okay. Thank you, Dr. Mark. Dr. Mustafa, please raise your hand because there are many Mustafa in this meeting. I can't recognize who is the one. Dr. Mustafa, if you hear me, please raise your hand.
Hello, assalamu alaikum.
Walaikum assalam. Okay, so this session will be with Dr. Shayma and Dr. Mustafa. Each question for each of you. We will start with Dr. Shayma. Your stem is a 45-year-old female patient. No case of rheumatoid arthritis on steroids, now is going for surgery. Dr. Shayma, what is steroid?
It is organic compound that containing a characteristic arrangement of 4 cycloalkyl changes that link it together.
Dr. Mustafa, what are the layers of adrenal cortex and what does each layer secrete?
Sorry. Adrena fasciculata. Fasciculata Yes, producing cortisol, and glomerulosa producing aldosterone, and the reticularis producing sex hormones.
What are the actions of aldosterone and cortisol, Dr. Shima?
The aldosterone responsible for sodium reabsorption and potassium excretion in the distal convoluted tubules and collecting ducts, and it's also responsible for water balance through the salt and water retention, and have a role in acid-base balance through excretion of potassium and correction of hyperkalemia.
And what about cortisol?
The cortisone have anti-insulin effect and anti-inflammatory effect, also have immunosuppression effect, have a role in regulation body stress response, stimulate gluconeogenesis, increasing glucose in the blood, and stimulate protein synthesis, especially in the liver, stimulate lipolysis, and have also aldosterone effect.
Yes, mineralocorticoids effect. Who should be involved in surgery for this patient, Dr. Mustafa?
Endocrine specialty.
Describe hypophyseal pituitary adrenal axis with hormones and negative feedback.
Okay, the hypothalamus will excrete corticotrophic releasing hormone, which is going to pituitary, anterior pituitary, which excrete ACTH, and then it will go to adrenal cortex and secrete cortisol and aldosterone. And the circulating cortisol and aldosterone will giving negative feedback to anterior pituitary and to hypothalamus.
In pituitary hypophyseal, in pituitary hypoplasia, which hormone is affected? Dr. Mustafa.
ACTH. ACTH hormone.
Dr. Shaima, adrenal insufficiency, which hormone is affected?
The cortisone as well as aldosterone.
How to optimize a patient taking steroid pre-operative, Dr. Mustafa?
So it's according to the dose. If the dose less than 10 milligram, so patient will take the same dose. If it is more than 10 milligram, I will give patient 100 milligram at induction plus the original dose of the patient. Then I will give maintenance 200 milligram, 200 milligram hydrocortisone.
For how long?
Sorry?
For how long?
For the first 48 hour, then I will increase the dose. For 24 hours, then the second day for 100 milligram. But I didn't remember. Yeah, I didn't.
Till the patient can tolerate oral intake, then you will return him to his primary pre-operative dose.
Yes.
Dr. Shaima, how to educate patients starting steroids?
Okay, I will tell the patient not to stop steroid abruptly, and he should taper it off, and make the doctor aware that he is taking steroid every time he's going to hospital or doing surgery, and wearing a steroid card. And I will tell the patient that steroid will leading to weight gain and muscle weakness, behavioral and mood changes, and will increasing risk of peptic ulcer. So should take care of non-steroid anti-inflammatory drugs, and the patient will, and steroid will affect the blood glucose. So the patient, if diabetic, that will leading to poor diabetic control, and if not, will develop diabetes. Also, steroid can lead to osteoporosis.
Dr. Mustafa, what are the complications of steroids management?
So the increased diabetes mellitus, osteoporosis, increased incidence of peptic ulceration, increased risk of infection, sudden arrest lead to Addisonian crisis. Hypertension also.
Yes. And coarse facial features, all these complications. What is your considerations in a patient going for surgery, but he is on steroid or she is on steroid, Dr. Shema?
First, the dysonium crisis, and the patient have increasing susceptibility to infection. There's possibility of chest infections, and poor wound healing post-operatively.
Excellent. Dr. Mustafa, what are the anesthetic considerations in a patient with steroids?
Pass. No, I didn't eat it.
Dr. Shema, could you answer?
Yes, the diabetes, hypertension, hypocalcemia, no, the chest infection.
Electrolyte imbalance generally.
Yes, and chest infection, most important, that's it, a dysonium crisis.
Excellent. What do you know about the dysonium crisis, Dr. Mustafa?
So it is acute reduction of the circulating steroid. It's either primary or secondary. Secondary may be due to trauma, surgery, infection, or sudden stop of the exogenous steroid hydrocortisone.
Excellent. Okay, well done, both of you. I think it was a straightforward station, and you did great in it. Dr. Salah, do you have more questions or any comment further?
Hello?
Yes, Dr. Salah.
Okay. Today, I told you pancreatitis not came. I just now received Penang day 2 exam. They have pancreatitis in their exam today. Tamam? They have pancreatitis in their exam. Plus, the station of today, calcium homeostasis beta diarrhea, and they have also, no, this is not today. 14 النهارده كان 15 this yesterday. Okay, so today they have pancreatitis. Regarding of steroid, every time this station is coming, it's very easy and is going exactly by this way. About optimization of steroid, you should start first by this way when you are answering this question by 4 marks. You should start, okay, according to the new guidelines. According to the new guidelines, I will do optimization like this way. And you should show him that if he will ask you have all the guidelines, because I remember in May 2021, when our candidate started to answer the question according to the new guidelines, examiner was very happy in UK. يعني هم مستنيين النيو guidelines. اوكي يلا اللي بعده.
Dr. Minam Shami, please raise your hand. Actually, it's very difficult to go down and search for each candidate one by one. Dr. Adnan, please unmute your mic.
Hello, Dr. Suzanne. Hello, Dr. Salah.
يا مرحبا اهلا وسهلا.
I will open only for the people who raise their hands. I can't find a name among 77. Okay, Dr. Adnan, your stain is a female presented with epigastric pain, nausea, vomiting, and diarrhea. Labs showed increased bilirubin, ALT, alkaline phosphatase, GGT, and neurobilinogen is undetected in her urine. What is the type of jaundice this patient is having?
This is obstructive jaundice or post-hepatic jaundice.
In what form does the bilirubin circulate within the plasma?
Circulating as free bilirubin or unconjugated.
How bilirubin formed and how does it circulate? Neurobilinogen, sorry.
It's a byproduct of bilirubin metabolism, and it's formed by the intestine of the flora, and it's excreted in feces after oxidation into stercobilinogen, and some of it will be reabsorbed into portal circulation again. And the reabsorbed urobilinogen is again excreted by the liver and intersystemic circulation and goes to the kidney and is excreted in urine.
Yes, and it gives the urine its yellow color. Why it's absent in urine in this patient?
Because the obstruction of the flow of bile and the bilirubin not reach the gut.
What is the physiological role of bile salts and how they achieve this function?
Their physiological route by digestion and absorption of fat, by emulsification of fat into muscles, so increase the surface area for action of the pancreatic enzymes.
Excellent. What is bilirubin conjugated to?
To glucuronic acid.
Talk about bilirubin metabolism, please.
The conjugated bilirubin goes to the bile and then to the small intestine, which then goes to the bile. Then in the intestine, it's most of the bile acids will be reabsorbed into the L-terminal ileum. The conjugated bilirubin it will pass to the colon, where in the colon is disconjugated by the colon bacteria. I'm sorry, and metabolized the bilirubin into urobilinogen, which oxidizes to form stercobilin, which gives the stool its color. And about 10% of urobilinogen is reabsorbed into the enterohepatic circulation to be excreted in the bile, and some by the kidney.
Which clotting studies could be deranged in this patient?
The prothrombin time and the INR.
How to correct this clotting abnormality?
Give IV vitamin K, fresh frozen plasma, and prothrombin complex concentrates, and also consult a hematologist.
Yes, it should be corrected according to the situation of the patient. If he is going for emergency surgery, for sure we will not give vitamin K because it takes long time to start. So we'll give the fresh frozen plasma and the CCP. How enterohepatic circulation of bile maintain the bile salts pool in a healthy adult? Define enterohepatic circulation in other words.
The amount that lost in the feces, it will be replaced by the enterohepatic circulation as the liver synthesizes small amount of bile salt to replace.
Please give me in numbers. What is the ratio that will be excreted and how much will be reabsorbed?
About 90%.
Continue.
About 90% it will be reabsorbed. I will pass.
More than 90% of bile salts excreted in bile are actively reabsorbed in the terminal ileum. 5% reabsorbed in the colon. They enter the portal circulation, they're reabsorbed by the liver and they excreted in bile. Liver sensitizes small amount of salt daily to replace that lost in stool. So it will be less than 5%. Okay, so what could be the cause of silent obstructive jaundice? This question answered before.
Cancer head of pancreas.
Or was there low? What other investigations you want to do if you find a CBD stone in ultrasound?
Endoscopic retrograde cholangiopancreatograph.
If the patient has fever, pain, and chills, what is the cause? What is the diagnosis and how to manage it?
Ascending cholangitis.
How to manage it?
I will manage the patient according to CRISP protocol and also.
Please
according
don't
to-
tell
okay.
abbreviations.
Okay, so according to critically care ill surgical patient and protocol and according to sepsis 6, I will administer high flow oxygen to keep it more than 94%. Take blood cultures and consider infective source, chest X-ray and urine analysis. I start IV antibiotics according to trust protocol. Also give intravenous fluids resuscitation and serial lactate and hemoglobin and also urine output measurement every hour.
Ganoesophageoscope be used to perform an ERCP and why?
No, because the opening in the esophagoscope is anterior scope and the RCB is the side scope, so allow the cannulate.
Yes, as you see here, this is ordinary esophagoscope. Its opening is for the instrumentation is in the front, so we call it enteroscope. And here the ERCP, the opening is in the side, so we call it cydoscope, so we can cannulate the common bile duct and the pancreatic. That's easy with it. Okay, I finished this station. Dr. Salah, do you have any comment or you want to add any question for him?
You for ascending cholangitis?
Yes,
6 sepsis 6.
yes, he mentioned it.
انت سالتهم ولا ما خدتش بالي؟ سالتهم؟
Yes, he mentioned all of them.
طيب يبقى انا كنت تهت منك. ماشي، لان كنت بجهز حاجه. So in this station we'll ask you at the end about the causes, classify jaundice, then classify obstructive jaundice as you told in previous station, plus if patient has rigorous fever and jaundice, what you think ascending cholangitis, how to manage patient with ascending cholangitis. We'll start first by according to care of yes هو قال كريسب صح، انا وصلت سمعت تاني. According to care of critical ill surgical patient and sepsis 6, then you will go for ERCP for patient with ascending cholangitis. Okay, next station.
Dr. Ahmed Ali and Dr. Isra, please unmute your mics. Hello.
Hello. Suzanne, how are you?
Yes, I can. Yes, I can hear you now. Dr. Isra, please unmute your mic.
Hello. Hello, Dr.
Hello, how are you?
How are you,
Fine,
Dr.
alhamdulillah.
Susan?
Okay, so Dr. Ahmed will be first, then Dr. Isra. Are you ready?
Yes.
Okay, you're standing a 60-year-old chief involved in a fire. He was trapped in the kitchen for 30 minutes when he was brought to the ER. His pulse was 120 per minute and the blood pressure was 90/50 millimeter mercury. He sustained burns covering his chest and abdomen, right and left lower limb and right upper limb. He was in severe pain. The burns looked erythematous with blisters. There was some soot around his mouth and nose. The burned area was 63%. Upon asking his friends, he said that he was able to jump from the window on the first floor. Dr. Ahmed, what is the degree of burn in this scenario?
Due to the erythematous and blisters, partial sickness. Burn.
Dr. Isra, how you are going to manage this patient?
Yes, I will manage the patient according to ATLS, advanced traumatic, I don't know the LS.
Advanced trauma life support.
Yes, ABCDE, the airway. I will start with airway to look for any sign of airway obstruction or any foreign body. And
in this patient, how you are going to manage the airway?
The airway?
Yes.
Yes, the important thing is to look for any sign of airway aspirate, smoked, like any smoked area around the nostril.
So do you have or not?
Yes.
So what will be the management?
Intubation for
prophylactic intubation.
Prophylactic, yes.
Continue.
And the breathing and ventilation. This for ensure that adequate ventilatory state for the patient, and the most important, I will start to put oxygenation of the patient according to his situation, and the circulation.
Wait.
Yes.
You told that you need to ensure adequate ventilation.
Yes.
What to look for in this patient to make sure that the ventilation will be adequate?
Yes, first of all, I will be sure about entry bilaterally, and I will look for examine the chest expansion for any compartment syndrome, to do ischiotomy for
yes,
there
you
is
have
fibrosis.
to examine the patient for full thickness circumferential chest burn.
Yes.
Not the air entry for him, or not the expansion. From the beginning, you will look for the burn itself. If it is full thickness circumferential, then you need to do ischiotomy, as you mentioned. Excellent. Continue.
Yes. C, circulation for, I will put 2 large bore cannula, and fluid resuscitation. I will start with crystalloid according to Parkland formula. 4 mil multiplied by total burn surface area, the percentage, and
this is the old or the new Parkland formula?
4 is the new.
This is the old one.
Old.
The new is 2.
2. Yes.
The new one 4 only for electrical burn. What is your target while you are giving this fluid? What is your resuscitation endpoint?
The target?
Yes. Or the resuscitation endpoint?
The patient response regarding after putting the urine output for the patient and the vital sign.
How much urine output?
It should be 0.5 to 1 mol per kg per hour.
Excellent.
Yes.
Which fluid to give, colloid or crystalloid, and why, Dr. Ahmed?
I will give crystalloid as there is increase in the capillary permeability due to the burn. So I shouldn't give colloid in the first 24 hours to avoid the augmentation of the surface space due to increasing the osmotic pressure.
Excellent. Mention 5 complications of burn, Dr. Isa.
Yes, the most common complication is shock, hypovolemic shock, sepsis, acute respiratory distress syndrome, and the patient may require ischiotomy.
Yes, and constricting circumferential burns.
Yes.
What else?
Electrolyte imbalance. Yes.
Renal failure due to myoglobinuria, coagulopathy, DIC, and hypothermia.
Yes.
Excellent. Dr. Ahmed, 4 days later, the patient developed tachypnea with respiratory rate of 28 per minute and oxygen saturation of 88% on room air. X-ray test done. On the light of this X-ray given to you, what is your diagnosis and what other differential do you know?
There is a diffuse pulmonary infiltrate denoting acute respiratory distress syndrome, but I have also to suspect pneumonia.
What else?
What else? Pulmonary edema. Pulmonary edema.
Yes, first of all, pulmonary edema, then pneumonia, overload, whatever. Dr. Isra, what is the definition of ARDS?
The definition, it's acute diffuse form of lung injury. Should I mention the characteristics?
For sure, we need full definition.
Yes, okay. So it's characterized by refractory hypoxemia, and there will be pulmonary wedge pressure normal or less than 18. The lung compliance will decrease, and there will be infiltration, bilateral pulmonary infiltration on chest X-ray. And the ratio of partial pressure of oxygen and the FiO2, the inspired oxygenated air, it will be less than 26.6.
What are the causes for ARDS, Dr. Ahmed? What are the possible causes for it?
Causes of ARDS, mainly infection, sepsis, in this patient or in general?
General.
Infection, sepsis, pancreatitis, DIC, burns, trauma, and transfusion lung injury.
Yes. What is the management plan for this patient with ARDS, Dr. Isra?
Yes, I will manage the case of ARDS. First of all, I should admission the patient to the ITU, starting with respiratory support by giving oxygen in the ventilator PEEP. I forget the abbreviation.
Positive and expiratory.
Expiratory pressure, yes, it should be low pressure, high rate, and the patient on prone position. We can give steroid, start low dose of steroid can improve his situation. If there is the hemodynamic state management by starting by fluid and monitoring the fluid. And the supportive care can be by nutritional support. And
finish the hemodynamic status management first. What else rather than fluid could be used?
Fluid.
If your patient is in circulatory failure.
Yes. Yes, if no response, refractory hypotension, we can give low dose dopamine.
Or dobutamine. And how you are going to assess your hemodynamic status of your patient?
By Gans catheter.
What you will measure by this catheter?
Yes, I should measure, I will look for pulmonary edema.
Yes, so
yes, pulmonary wedge pressure.
Yes, pulmonary wedge pressure, urine output, and blood pressure.
Yes.
Then?
Supportive care by nutritional support with the patient. It's better to start with enteral feeding and thromboembolism prevention by start with Glixan, low molecular weight heparin, and to prevent the gastric ulcer by giving prophylactic proton pump inhibitor.
Excellent. What are the long-term sequelae of ARDS, Dr. Ahmed?
The long-term sequel, ventilation perfusion mismatch, and pulmonary hypertension.
And physiological shunt for sure. Okay, I finished this station. Dr. Salah, do you want to add any question for them, or you have any comment rather than their great performance, mashallah?
امتحانكم امتى يا احمد انت واسراء؟ امتحانكم امتى؟
2 فبراير يا باشا. 2 فبراير.
أنا ماي.
وبتشارك من دلوقتي. انا عارف انك ما حجزتيش في الفتره اللي جايه. So when you are doing amazing by this way and your free group, I advise all people to join this group. يلا هفتح عليكم. I advise people to join this Iraqi group. العراقيين يا شباب مفتريين، خدوا بالكم يعني. ماشي، مش مفوتين حاجه. الناس دي بتذاكر ليل نهار. ده انا بخلص اللايف يا سوزان بيروحوا يذاكروا. اوكي. اوكي they are doing great by the way. ايوه ذكي. ما بلاش انت يعني بقى الرينال فيلير بسبب هايبر كالسيميا. انا ما علقتش وسبتك النهارده لان طالع من العمليات مصدع. انا يمكن النهارده مش في المود يعني. انا جاي من العمليات على طول على اللايف. فاللي بقى الرينال فيلير بيعمل هايبر كالسيميا. ارجعك بارتي تاني، ارجعك تاني. استغفر الله العظيم. طيب اوكي. About this station came in last time in Cairo. When came in Cairo last time, it was in December 2021. The first exam after Corona in Cairo. They told about this station, everything is going exactly like this mock. By the way, most of the updated, like sequely, like Berlin criteria, all of this is my notes, Salah notes in part B, but we added in the book. So if you look to the book, you will find everything, even my notes for part B in this station in our book, updated. The only two questions here about Dr. Susan asked, he will show you picture for ARDS and will ask you what is your differential diagnosis. He's waiting pulmonary edema first. Yani first ARDS, then pulmonary edema. And according to the scenario, patient has erythema blisters. Patient has erythema and blisters, and will ask you what is the degree of the burn. It's a partial sickness. It's a partial sickness. He's waiting these two words. In other center before, Suzanne shared for you from Suzanne. She shared for you about one important paper about the types, degree, or classification of burns according. And what is the classification of burns? This asked before. This question asked before in one center before. I remember this station will start by Barclay formula. If you will go to the station and they will ask you how to calculate the fluid, you will tell him according to the latest ATLS, it will be the Barclay formula. It will be the percentage multiplied by the weight multiplied by 2, not 4. Tell him 2, not 4. This the updated ATLS. عندكم كده يا سوزان ولا عندكم حاجه ثانيه؟
Yeah, that's it as you mentioned, Dr. Salah. Dr. Salah, excuse me, I have to leave just for 10 minutes and I will be back.
هناخد بريك. انت فرمتنا النهارده. هناخد بريك. خلاص هناخد بريك. Okay. Now I wanted to go for another important topic. Is this for your knowledge? Only not asked. He's asking about ايوه شكرا. كلامك كل اللي انت كاتبه مفتوح اهوت. اوكي. About ventilations. مين اللي كاتب الورقه دي؟ I know you are here. Okay. Who's writing this paper? One of you. مين يا شباب اللي كاتب الورقه دي وكان بعتها لي؟ عدنان مصراتر. طيب تمام. اهو يا عم كل واحد بياخد حقه. ماشي، كل واحد بياخد حقه. دي عدنان مصراتر يا شباب. عامل ورق جميل جدا جدا. He has many things done, especially this and the lung volumes. يا اخوانا بصوا ما تزعلوش مني يعني، ما تزعلوش مني. بس العراقيين والليبيين الناس دي كرياتيف. المصريين والسودانيين ما فيهمش بوردر لاين. يا كرييتيف على الاخر يا ضايع على الاخر، وما اعرفش انتوا ايه فيهم بصراحه، فمش هتكلم يعني. اوكي. طيب يثبت تقريبا. ايوه. وبرضه الدكتور هدير لها نوتس رهيبه جدا في البلاستيك، بشيرها كلها باساميكم دلوقتي يعني. ماشي. respiratory failure by CPAP ARDS early stages by CPAP and later BEEP BCV IRV. Okay. How to manage ARDS early by CPAP. What is CPAP? Continuous positive continuous positive pressure. Okay. Patient will initiate only his breathing, then you will support by continuous pressure. Then in later stages, you can go for BEEP, which is positive expiratory pressure, and this is at expiration, but BEEP should be adjusted, not to cause barotrauma. How to adjust BEEP? Give fixed volume or high volume with low pressure to avoid barotrauma. Okay, so you should adjust BEEP. BCV, pressure controlled ventilation, this giving you fixed square area of ventilation, so will not go for barotrauma also. Or inverse respiratory ratio. The normal inspiration to expiration is 1 to 2. This patient has hypoxemia, refractory hypoxemia, so your target to improve him. So increase the timing of inspiration, so you will inverse the ratio. Yeah, inspiration to expiration is 1 to 2. So inverse the ratio means 2 to 1. Inspiration is more than this. This is the most common ways will be used in ARDS. Okay, clear? غلطتك يا عدنان انك لما عملت الورق ده ما كتبتش عليه اسمك تحت، لكن ما تقلقش انا مش ناسي يعني. اوكي take 10 minutes break then we'll be back. معناها we have remaining 3 stations only, very small stations, so 3 minutes then we'll be 10 minutes then we'll be back. يلا يا شباب.
Dr. Nurhan, could you unmute your mic, please?
She's
We're sharing the same mic.
okay.
ما شاء الله.
بقت اجريسيف، هي عارفه ان
الله
انت
ينور.
فبترد
الله
عليك.
ينور.
والله العظيم صح.
اوكي زي الفل. بيوفروا نتورك على حساب.
لا
مفيش مشاكل.
عشان بس الباك جراوند نويز ما يبقاش فيه ايكو.
لا مفيش مشاكل، مفيش مشاكل خالص والله.
اوكي دكتور سوزان.
Okay. You remind me by Bangladeshi couple. They passed, by the way, from the first time with great scores. So I hope that the same for you. Inshallah. Your stem is a male patient, post-operative day 3, post-sigmoid colectomy for cancer. He has tachycardia, tachypnea, and fever. On examination, his pulse is 110. Partial oxygen pressure was 90%, and my respiratory rate is 24, and blood pressure is 110/70. What is your differential diagnosis for this patient?
My differential diagnosis for this patient, it could be pulmonary embolism. The patient may have chest infection, basal atelectasis, abdominal sepsis, or fluid overload, as in heart failure.
Excellent. Dr. Nurhan, why PE is suspected in this patient? What are the risk factors for PE in another way?
Hypercoagulability, as the patient has post-sigmoid colonectomy for cancer, as the patient has cancer. And his clinical symptoms as tachycardia, tachypnea, decrease in partial oxygen pressure, and also the patient is post-operative.
It's post-operative for a long procedure for sure. How to approach this patient, Dr. Abdurrahman?
First of all, I will manage this patient according to the care of critically ill surgical patients protocol, starting with ensuring that the patient has a patent airway. If the patient starts talking, then we're going to add a rebreathable mask on 10 to 12 liter oxygen, so that the patient saturation would reach 95 or above percentage. Then we're going to call the ITU resident to be on standby if the patient needs or indicated for intubation. Then I will reassess and manage the circulation according to the peripheral warmth and capillary refill. And I will assess the patient's vitals. I will insert 2 wide bore cannulae and start fluid resuscitation and reassess the circulation according to the pulse, blood pressure, and capillary refill, as well as the urinary output. After this, I will inform my consultant. Then order investigations that would
Not then.
direct me.
In the same time, you will take the sample. When you
Yes,
put the cannula, you will take the sample.
Exactly, so that I would not withdraw 2 samples. Then the investigations I will order would be to guide me towards my diagnosis.
What investigations you are gonna order?
I will order ABG, ECG, chest X-ray, and this is something I would do personally. I would do D-dimer to see for fibrinogen degradation products, and chest X-ray, as well as CT angiography.
CT pulmonary angiography.
Oh, okay.
Okay, showing the following ABG readings. What is your diagnosis, Dr. Nurhan?
It's respiratory alkalosis.
Sorry?
Respiratory alkalosis.
You are asking me? I don't know.
I'm speaking. Respiratory alkalosis.
Yes, like this. Be confident. That will give a very nice impression about you. Why do you think this patient is having this respiratory alkalosis, Dr. Abdurrahman?
Because of hyperventilation to wash the excess carbon dioxide.
Given the following ECG, what is your diagnosis, Dr. Nurhan?
Tachycardia.
Which type of tachycardia?
Sinus tachycardia.
Yes, full answer, please. What is the golden standard investigation for pulmonary embolism, Dr. Abdurrahman?
CT pulmonary angiography.
Dr. Nurhan, could you comment on the following CTPA?
There is filling defects in the pulmonary vessels, which may suggest pulmonary embolism, large one.
What is the pathogenesis of clot formation, Dr. Abdurrahman?
First of all, an epithelial injury happens, which triggers the coagulation pathway, and there will happen platelet aggregation and platelet activation, as well as intrinsic pathway activation. Oh, I said it.
Excellent. Okay. I finished this station. It is one of the new stations as you find on our drive. Dr. Salah, do you have any updates or any questions for them?
Go back. This station came for the first time in UK, I think, October 2021.
Yes.
October 2021. Okay. in UK, and this patient came in Kuala Lumpur last September exam. Exactly what will happen in the station. We will ask you how to approach the patient. He will tell, I will do for the patient. He will ask you what is the investigation. You will tell him, I will do EBG. He will give you, this is the EBG. He will not show you. He will not show you the EBG, except if you will tell, I will do EBG. So please, يعني, some of you will tell, it, yes, the numbers, I get it. The number, I get it. واحد مدينا الأرقام دي مظبوط. This numbers, I get it. Somebody send for me this numbers, these parameters. Okay, so he will not show you EBG except if you will tell, I will do EBG, and I will do ECG. Give next picture, Suzanne. I will give you the ECG, and this is the ECG. So please concentrate. He will not show you this except if you will ask. This sinus tachycardia. I don't know why some of you will go for ECG. I'm afraid. Atrial fibrillation. Yalla, finish. What is atrial fibrillation? I know. I can this sinus tachycardia plus S1 T3 Q3. So S wave in lead 1, inverted T in lead 3. What's this? What's this? Don't tell anything. ما انا بقول لك بقى، انا بقول لكم اللي بيحصل في الامتحان. You think exam will be easy like this way? It will be easy. But you started with stress to think. ولما بتبدا تفكر بتغلط. When you start to think, you will do some mistakes. So ECG here, sinus tachycardia. Then you will tell, I will do CTPA. He will show you the CTPA. ذكي، ما تعملش نفسك ذكي. خلاص، زي ما بنقول كده بالظبط. Okay. If you will find AF, tell him there is AF. ماشي. Only one question here in pulmonary embolism, and not satisfied about it. I don't know, ask it here or in history or in yes, here or history. I think I don't know here or history. He's asking about if you are scrubbed here. No, ask it here. If you are scrubbed and nurse called you about patient with BE, what you will do? Yalla Rahman.
If I am scrubbed, I will inform the consultant or the senior with me on the operating theater and ask if he urgently needs me, or I can scrub out so that I can check the patient.
Wrong, Nurhan.
The patient we're operating on has pulmonary embolism, or a patient in
No, you
another
are
ward?
scrubbed for another case and they called you for patient in ward developed BE.
I will ask the nurse to inform the senior, my colleague, surgery colleague in the ward,
to follow with the patient because I'm already scrubbed in a patient.
بيعملوا ايه لما يلاقوا patient pulmonary embolism او critical patient? What they are doing?
بيجيبوا دكتور الرعاية.
Announce what?
ايه؟ rapid response team.
I'll call the response.
The rapid response team.
RRT. Not code blue, Ahmed. Not code blue for arrested. There is difference. Code blue for arrested. RR team or crash call. Name the crash call. يعني they are telling it crash call. Okay. What else? Not accepted. This answer only not accepted.
Tell the patient,
Tell the nurse to transfer the patient to the ITU and start anticoagulants.
Inform ITU. Inform ITU.
لا، ممكن اطلب الانفستيجيشنز بتاعت البلمونري امبوليزم من النيرس على بال ما اخلص العمليه.
انت مش عارف you are scrub. How you will inform to do investigations giving orders? Just if nurse called me that, I will inform my consultant, I will inform my ITU registrar to follow the patient, and I will ask to start therapeutic dose of heparin and crash call.
Okay.
يبقى crash call, inform my consultant, inform my ITU registrar, and I will advise to start therapeutic dose of Clixel. This is the answer only accepted. Transfer where?
طب دكتور صلاح يعني السؤال اللي حضرتك بتسأله ده سؤال من اللي هو البروفيشناليزم اللي هم، ولا ده سؤال عادي؟
لا اتسال في اللجنه دي.
طيب هو ايه يعني عشان برضو الواحد مش عارف ايه موضوع الماركس بتاعت البروفيشناليزم، او المفروض ان هو يانتسيبيت الموضوع ازاي؟
يعني سؤالها ايه؟ السؤال بتاعها داخل اسئله الشرح بتاعك كنت بتشرح. يعني فور اكزامبل، يعني هي قالت لك ايه؟ تاكيكارديا، ما هي كده هتخسر الدرجه. ساينس تاكيكارديا I can see now the rate of the patient is very rapid and it's regular, so this is sinus tachycardia. This is a professionalism. Come for EBG, you told respiratory alkalosis. Tell me here pH is high and BCO2 is low, so this is respiratory alkalosis. This is how to get professional marks. مش انتوا تقولوا respiratory alkalosis. مش كده. يلا.
ثانك يو دكتور صلاح، ثانك يو دكتور سوزان.
انا ما شفتش كام يعني read the parameters and explain why you told respiratory alkalosis. This is what I mean. يلا سوزان next station.
Okay, Dr. Mansour, where are you? And Dr. Widad. Dr. Mansour, please unmute your mic, and Dr. Widad as well.
السلام عليكم.
وعليكم السلام يا هلا. Dr. Widad, please unmute your mic.
السلام عليكم.
وعليكم السلام ورحمة الله.
Please keep me for the last session because still I am not reaching home. I am on the way to home.
Okay. So we will take Dr. Saeed. I hope this time I'm pronouncing your name in the right way.
سعيد يا دكتور، سعيد.
ما
سعيد
قلت
بالعيد.
سعيد والله. أنا قلت سعيد والله.
اوكي.
ويعني هي غلطت في البخاري، سعيد من سعيد، هي غلطت في البخاري. يلا يا عم.
يا باشا خليك معانا على الخط يا باشا، انت بتابعنا.
ماشي.
ماشي يا باشا.
لا ده هو صلاح السيد، ده هيحب السيد أكثر من سعيد، طبيعي يعني. Okay, so Dr. Mansour and Dr. Saeed, your STEM is a 65-year-old lady presented with long-standing goiter, malaise, and chronic fatigue. Her full blood count and full biochemical profile reviewed as part of her assessment and showed low T3 and T4, high TSH along with macrocytic anemia.
By the way, this station came yesterday in Penang. Yesterday. Came yesterday.
Very nice. Okay, so we'll start with Dr. Mansour, question by question for each of you. What is the most clinical diagnosis?
According to the clinical sign and symptoms in the STEM, and according to the thyroid function test, this patient suffering of hypothyroidism.
Dr. Saeed, please describe the physiological regulation of thyroid hormones.
Thyroid hormones release its hormones depending on thyroid stimulating hormone that's secreting from anterior pituitary, which releasing in response to thyrotropin releasing hormone. This is from hypothalamus. Then secrete thyroxine from thyroid, leading to negative feedback, inhibit the pituitary and inhibit the hypothalamus.
Dr. Mansour, what are the differences between T3 and T4?
T3 is more biologically active and less bounding to the plasma protein.
What else? No other differences between them?
What?
No other differences between them?
Maybe because the T3 is component from two organs of diiodotyrosine and monoiodotyrosine, and T4 is the two organs of diiodotyrosine.
Excellent. There is a structural difference between each of them. Dr. Saeed, talk about synthesis of T3 and T4.
iodine ions enter the thyroid, then by active bumping inside follicular cells, leading to confirmation from iodine into tyrosine, then monoiodotyrosine, then diiodotyrosine,
How it
monoiodotyrosine.
converted from iodine to tyrosine? And it is
Iodine
not
combined
converted
with
to, it is not converted to
combined with
tyrosine, it is
tyrosine.
converted to iodine, iodide to iodine. By which enzyme?
Tyrosinase. I don't
Tyrosine
know.
peroxidase.
Tyrosine peroxidase. Okay.
Then continue.
Then diiodotyrosine with monoiodotyrosine form T3. Diiodotyrosine both with each other form T4.
Okay. What are the clinical features of hypothyroidism, Dr. Mansour?
The patient always suffering of bradycardia, constipation. Also, the patient have a muscular weakness, peritibial myxedema, and weight gain and memory loss.
Mention 3 causes of hypothyroidism, Dr. Said.
Accordingly, it may be autoimmune like Hashimoto's thyroiditis and primary hypothyroidism, and drugs like irradiations.
Iatrogenic,
surgery.
like post-operative post-radioactive iodine or post-radical
Surgery.
radiotherapy.
Yes. But by the way, clinical picture of hypothyroidism, I think this is lady. So I should say meniscus disturbance. This is the most important. I think this.
You think, but anyway, he wants some of the clinical features which he mentioned already in the right way. Thank you. Dr. Mansour, if hypothyroidism is secondary to hypopituitarism, how thyroid function tests could differ?
I will find low TSH, low T4, low T3.
Yes, so the difference will be low TSH with the T3 and T4, not like in primary. From the full blood count finding given, explain the cause. As mentioned to you, understand that this patient is having macrocytic anemia, Dr. Said.
Yes, macrocytic anemia usually is due to either vitamin B12 or folic acid deficiency. Here, I think it's due to vitamin B12 deficiency due to pernicious anemia as a part of autoimmune disease.
The autoimmune disease affect which part in this pernicious anemia?
It is affect stomach, especially parietal cells within the stomach.
Dr. Mansour, she was put on medical therapy. She is not compliant to treatment. Which team should be involved in management of her condition?
I have to involve the endocrinologist, the anesthesia consultant, and the surgical consultant. Also, I have to involve her relatives and her GB.
Excellent. You have to mention her BP. Very well. Very good. Okay, Dr. Said, what are the problems associated with emergency surgery in a patient with hypothyroidism? Or what is the surgical considerations?
Surgical considerations, it can be divided into before the operation, can be due to anemia, due to decreased basal metabolic rate, and increased risk of ischemic heart and hypothermia. Intraoperative, it may be bradycardia or hypotension, maybe coagulopathy due to decreased circulatory response. Post-operatively, delayed recovery and confusion and decreased wound healing and increased risk of infection with myxedema.
By the way, hypothermia is intraoperative consideration, not preoperative, because preoperative she will be covered. But intraoperative, she could. Hypothermia is intraoperative. concern or consideration. Okay.
Okay.
How to improve the patient's compliance to thyroid replacement therapy, Dr. Mansour?
First thing, I will call the patient and discuss his non-compliance with him. Is it about social problems or psychological problems? Second thing, I will ask his relative and involve them in the discussion. Also, I will try to contact his GP. I will try to change his regime to the simple regime, which make his dose is once in a day, and better it's to be in the morning. Also, I will try to discuss with him the complication of this non-compliance and the interruption of his therapy.
Yes, and you have to make for him a regimen for medical follow-up.
Yes.
Should be followed. Excellent. Okay, I feel this station. I don't have any extra questions. Dr. Salah, do you have any comment or you have any questions for them?
No.
Okay, thank you, Dr. Mansour and Dr. Saeed.
Thank you.
Okay, the feedback came from this hypothyroidism. It was a station that person went thyroidectomy, not having numbness along oral lips, and the thing is, the second question is the same of that of the like we did now. Only he asked me clinically, how will you check signs?
Signs of hypothyroidism.
I think no. I think this not came yesterday hypothyroidism. The one who sent for me hypothyroidism, it was hypocalcemia, and this is after thyroidectomy. I think because asking about the signs tapping facial, so this was hypocalcemia, and by mistake he told me hypothyroidism. I think hypothyroidism not came yesterday. It's hypocalcemia. تمام كده يلا بعد.
Okay, our last station is Dr. Widad and Dr. Hadir. Hello, Widad and Hadir, are you ready?
Yes, ready.
Okay, so you're staying with a 65-year-old man with diabetes type 2 on oral medication presented with perianal abscess, went for incision and drainage. Dr. Widad, what are the types of diabetes mellitus? Talk about pathogenesis of each of them.
There are two types of diabetes mellitus. It is type 1 diabetes, where there will be destruction of autoimmune destruction of the beta cells of Langerhans, leading to absolute insulin deficiency. Type 2, there will be combination of peripheral resistance to insulin and inadequate insulin secretions from the pancreas.
What are the functions of insulin, Dr. Hadir?
The principal metabolic function of insulin is to increase the rate of glucose transport by cells. It acts on carbohydrate by increasing the uptake of glucose in tissues, stimulate glycogenesis in many tissues, especially the liver, stimulate hepatic generation of glucose 6-phosphate. For protein, it enhances protein uptake. It enhances uptake of amino acids by peripheral tissue and stimulate protein synthesis. For fat, it stimulates the lipid uptake in the cells, and when in the cells, it enhances oxidation of lipids. Also cause fat deposition in the liver.
Okay, mention other hormones affect blood glucose level. How do they act? Dr. Widad.
Glucagon and catecholamines like epinephrine and norepinephrine and somatotropin from pituitary hormone and glucocorticoids. All they are increasing blood glucose because they are having action of anti-insulin effect.
What are the precautions of diabetes or diabetic patient going for surgery? In
patient
another
with-
word, how to prevent intraoperative hypoglycemia?
Okay. Patients with diabetes should be prioritized in the operation list. They shouldn't, starvation shouldn't exceed more than one missed meal. Analgesia should be used so a patient return to feeding early. Patients take insulin only if they are missing more than one insulin regimen. Monitoring glucose every hour during the operation and after it. Insulin, using the 0.45 sodium chloride, 5% glucose, and 0.150 kcal as IV fluid. Target blood glucose should be kept from 6 to 11 millimole per liter.
What about the glycemic control? How you will keep his blood sugar control?
By monitoring it every 1 hour.
So you will check it every 1 hour and you will not take any action, whatever it is low, high, whatever.
No, if it is low, we are giving the fluid which is containing 5%.
And if it is high?
If it is high, we give insulin regimen.
And what about his medications? What about his diabetic medication? He's on oral hypoglycemic agents. Is he gonna take his medication while he's going to surgery, or if you will be replace it with another medication? Give full plan, please.
If it is not uncontrolled, we convert it into insulin therapy.
Which type of insulin you will give, and what is the modality you will give in it?
Given it the subcutaneous type skip. No.
You will give him subcutaneous insulin while he's going for surgery or intraoperative?
No, so skip, don't know.
Dr. Ridat, could you answer this last point, please?
This I will start by sliding scale.
What is the other name for sliding scale?
I don't know.
Variable insulin infusion.
Variable
so it
insulin,
is not subcutaneous anyway. Okay. The glycemic control depends on the control of his diabetes. If it is tightly controlled, then you just stop the morning dose. And if it is uncontrolled, we'll shift the patient for variable insulin infusion, which is a sliding scale. And the other points as we mentioned. Dr. Irad, what are the suspected post-operative complications?
Wait, Dr. Suzanne. Wait, sorry. Prepare yourself because I want to discuss with you some questions. The patient is going by this way, and he's concerning mainly for optimization of the patient. So what are you going to do for this patient? Only that the question asked by this way. What are you going to do for this patient? For good precautions. What you are doing, patient is going for surgery. What you are doing for this patient? Answer.
Dr. Hadir.
I'm not getting it. What are you doing as a patient in Mrcs?
What will you are doing for this patient who is going for surgery? جاي لك patient diabetic on all medications and going for surgery now. What you will do? What you will do?
Monitor glucose first, then monitor glucose first, actually.
اللي عارف دكتورة ذات.
If his blood glucose controlled, I will start operation by monitoring this.
انا هسألكوا سؤال. جاي لكم مريض دايابيتك وداخل عمليات. التخدير هيقول لك ايه؟
Is his blood glucose controlled or no?
وايه تاني؟ البيشنت ده عنده اسيدوزيس ولا لا؟ البيشنت ده عنده
Yes, yes.
أنيميا ولا لا؟ البيشنت ده سكره كام؟ الروتين انفستيجيشن.
Yeah.
He's waiting this. He's waiting two things: ABG and potassium level. And they stuck in Dubai for this answer. معناها سهل. So when asking questions of DM patient going for surgery, you will tell I will do first labs for him like 1, 2, 3, 4, 5. Start how to optimize patient priority in OR, sliding scale, everything you are telling. Okay, what's the fluid you will give to this patient?
I will give dextrose.
ماشي.
Dextrose have normal saline with potassium.
Okay.
And glucose.
Yes.
كمل يا سوزان.
Okay, Dr. Widad, what are the suspected post-operative complications in this case?
He may develop immediate complications like hyperglycemia, hypoglycemia, electrolyte disturbance, or dehydration, or he may develop also DKA or hyperglycemic hyperosmolar coma. Also, late complications, he may develop infection, sepsis, and impaired wound healing.
Dr. Hadir, what labs should be done to prevent the immediate complications?
Monitoring glucose, blood glucose level, and APG.
What else?
Don't know.
Serum potassium. Just now, Dr. Salah mentioned. Dr. Widad, post-operative, who will be involved in care of this patient?
Endocrinology and his family.
And his GP for sure.
GP.
Okay, I finished this station. Dr. Salah, do you have any comment or you want to add anything for them?
انتوا مالكم النهارده انتوا الاثنين. عارفين لجنه سهله، لكن الطريقه اللي بيسالكم بيها الممتحن بتخليك تتصدموا وتقلقي، وده غلط ودي مشكله. Could you open the mic for دكتوره هيفاء? Raise your hand هيفاء please. طيب. Here Dubai exam. First case hypothyroidism. 65-year-old man like the stem Dr. Suhan did exactly. What is the most diagnosis, labs, what could be the cause of hypothyroidism in such patient, clinical features of hypothyroidism. Look for the full blood count again. You will find CBC, cytomega, the mean corpuscular volume will be high. So what is the abnormality for this patient? If mean corpuscular volume high, what's the type of anemia?
Galoblastic anemia, pernicious anemia.
And diabetic also should be, yes. So please concentrate about this point. What do you think happens for this patient hypothyroidism? Because patient after standing goiter, hypothyroidism, according to the clinical pictures, yeah. What are you going to, who will be involved in this patient, endocrinologist, according the patient is going for surgery or not. So it will be anesthesia also, and my consultant. What indication of thyroidectomy? Indication of thyroidectomy, شباب.
Yes, it could be cosmetic, for cosmetic reasons. It could be for malignancy.
Huge size compressing the trachea.
Symptoms or cancer or toxic nodule not responding for medical management. Okay, yes. And the patient request. Mentioned complications. I think we discussed it before. Complications can be hypothyroidism, hypocalcemia, and it can also be nerve injuries, vagus, recurrent laryngeal, and superior laryngeal. Then the pituitary is an axis already, or the axis we discussed it already. Diabetes mellitus station like we discussed. What they told me after the exam, they told exactly like our book. Started first by function of insulin, hormones affecting insulin, then types of diabetes, and concerning mainly about optimization of the patient, what is the medications and what is the fluid, how to give. Okay, this about this station also. Last one about the pulmonary embolism. It's no, it will be discussed later inshallah. Pulmonary embolism, it will be discussed. I think other station will be discussed later inshallah. دكتورة هيفاء
Yes.
عندك حاجة تانية تضيفيها؟
لا. في الhypothyroidism and complications of thyroidectomy, he told me to mention the complication and immediately mention the treatment of it.
That's very nice. So
Yes.
hypothyroidism, what you will do? Thyroxine.
Yes.
Thyroxine. Hypocalcemia, what you will do?
Hypocalcemia. Calcium gluconate.
Calcium supplementation.
Yes.
Okay. Nerve injuries, I will refer this patient for ENT for evaluation. And according is it reversible or not reversible? يعني by this way.
Yes.
ماشي. What else؟ طب احنا كده غطينا الأسئلة كلها ولا في حاجة تانية نسيناها؟
لا كلها. كان هو آخر question, last question was about the complications and treatment.
Okay. Thanks for all of you. شكرا دكتور سوزان. Tomorrow you will be off. You are lucky because I will call tomorrow. يعني just for this because I will call tomorrow. So after tomorrow إن شاء الله will be the next critical care mode. شكرا خير يا شباب إن شاء الله. شكرا سوزان.